Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome to another episode on the Health Trip Podcast. It is National Skin Health Month, and I am determined to help you all upgrade your skincare routine, including incorporating a preventive skin care health plan. A month ago, I was diagnosed with stage 1 melanoma, which I shared on social media if you follow me on Instagram or Facebook. And I'm also a postmenopausal woman. I use daily mineral sunscreen. I have no family history of skin cancer. I don't use tanning beds. I don't sit in the sun unprotected. I visit my dermatologist annually for mole checks because I do have a lot of moles. But this past visit, one of my moles on my neck had doubled in size in the year, and I had to have surgery where the oncologist removed a golf ball sized tumor, and I ended up with 100 stitches in my neck. And then off I went. I'll be fine. Thank goodness. But this prompted me to really bring awareness to skin cancer. And, I went into this not knowing a ton about skin cancer, the risk factors, and all of the ways in which we can protect ourselves. So my goal for you after listening to this episode, who I've invited on a very special guest, is for you to incorporate healthy lifestyle changes to minimize your risk of skin cancer and to implement a preventive healthcare plan to catch any abnormalities that may arise and catch them early. Skin cancer affects millions of people in the US every year, with the most being in aging adults. And that is one of the risk factors, just aging. As women age and we go through menopause, we experience a decrease in estrogen, which is something that negatively impacts our skin health and may play a role in the increased risk for skin damage. My guest today is Dr. Nita Ashurian. She is a double board certified dermatologist and Mohs surgeon. Dr. Ashurian completed an internal medicine internship at Indiana University, a dermatology residency at Rush University in Chicago, and a fellowship in Mohs micrographic surgery and cutaneous oncology at Northwestern Skin Care Institute. And before joining NWSCI, she was an assistant professor of dermatology at Northwestern Medical Faculty Foundation and the head of the department's dermatology services at Jesse Brown VA Hospital. So we are in good hands here. Short medical disclaimer. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. And consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dig into the ABCs of skin cancer. Hi, Dr. Ashurian. Welcome to the Health Trip Podcast.
Hi, Jill. I'm happy to be here.
I am so happy to have you on, and I'm so grateful that you took time out of your day to join the Health Trip Podcast, because skin cancer is an important topic for both men and women of all ages to know. My community is mostly midlife women. We talk about the perils of going through menopause, and our skin health is definitely up there at top of the list. But before we dive into all of the topics, I want to know what led you into even becoming an expert on skin cancer and becoming a dermatologist, right? Like all of you doctors, you go to med school, and at some point you have to decide what you're going to do.
Well, that's true. So I started my path thinking that I am actually going into a different specialty. During my fourth year in medical school, I took an elective rotation in dermatology and just fell in love with dermatology. It was partly because of the interface with immunology, a field that I had done research, basic science research in, and was very close to my heart. Partly because in dermatology, you see a wide range of ages, men, women, young adults, children. Dermatology allows you to do simple outpatient procedures. That was another attraction to me. So I chose dermatology, was lucky enough to be able to get a residency, become a general dermatologist. I practiced for 5 years. And during that time, I saw many patients with skin cancer. As you know, 1 in 5 Americans develops skin cancer during their lifetime. And my interest in treatment of skin cancer grew gradually. After 5 years that I had practiced general dermatology, I did a fellowship in Mohs micrographic surgery or dermatological surgery and chose to specialize in detection and treatment of skin cancer.
Well, we are lucky to have doctors like you because many dermatologists, and they do a wonderful job too. They service another population who want to do medical facials and beautify our skin. And you're more on the science end and looking at how can we prevent this terrible cancer, this disease that affects so many people.
We
So
are lucky that we have a variety of interests in different
yeah.
people, so we all can choose what suits us.
Right, absolutely. A wide spectrum. So, we're here to discuss skin health and skin cancer as it applies to midlife women. And we know going through midlife, I'm a postmenopausal woman. I'm close to being 57. And I've seen the changes in my own journey with the decline in estrogen. Now I take hormone replacement therapy, which really has helped me. I also have. My mom has beautiful skin. So my genetic skin makeup is good because she had wonderful skin. My grandmother had wonderful skin. But I have noticed differences, and I wanted you to start this episode by just talking about what midlife women should expect to see as we start to navigate the menopause transition.
Menopause and just getting older definitely affects our skin. We lose some of the elasticity, we become a little bit more um, vulnerable to environmental factors. But the good thing is that we are wiser and we are more proactive about our health. So we learn what to do and we are more willing to implement preventative factors that can help us, combat the skin cancer. As we get older, our body loses its ability to repair DNA. We know that ultraviolet is a carcinogen. And no matter what age we are, of course, ultraviolet is not good for our skin and can cause cancer. But especially as we get older and the UV induced DNA damage is not as efficiently repaired by our body as it was before when we were younger, it becomes more important for us to protect our skin. There are many risk factors for developing skin cancer, but some of those are environmental and we have control over them. And UV protection is the biggest one and the most important one. So I hope that all we women around this age are better at wearing our sunscreen every day throughout the year. UV light also goes through the clouds. So even on a day like we had today, when it's cloudy, about 80% of UV radiation penetrates and comes to the Earth's surface. So it's important to wear a good sunscreen.
That is so important to hear over and over again because when you live in a city or a town, wherever you are, and you do have these overcasts, like I have a friend that lives in Portland, Oregon, the sun is never really shining, right? And it's such a good reminder that it's that UV ray is still coming through, and it's important even on those days that you don't think you're getting sun, that direct sunlight, to still wear protection.
Correct.
Yeah. Let's move in. Before we move on, I wanted to ask you, as a young woman, when I was in my teens and my 20s, I grew up in a home that had a pool. So we were always outside. And, back then, and I'm sure women listening can identify with this, we were wearing baby oil, right? We were just frying in the sun day after day after day, not even thinking twice. Our mothers and fathers weren't even thinking about it because we didn't have the products around. As we age, you're saying it gets harder and harder for us to repair our DNA. Our DNA has a harder time repairing our skin. But if you were like me and in the sun like that for many years, like over decades, can you still help your skin in midlife from that time?
Jill, it's never too late. Some of the damage that was done years ago, unfortunately, is not reversible. Um,
Such as what? What's not reversible?
like if you have had sunburn, the research has shown that having 5 or more sunburns throughout the lifetime increases the risk of melanoma. So some of the damage that has been done is cumulative. So UV radiation affects our DNA, causes some changes in DNA that some of them can be lingering there and then get to the potential over time, like accumulate and get to the point that then give rise to skin cancer that we see. Some of that damage, unfortunately, is not reversible. However, protection going on is very important. I hear this misconception from some of my patients and friends that, oh, all the damage was done before I was 18. Unfortunately, there was a time that even maybe the doctors used to say that to their patients because we didn't know enough. But now, with the new science, we know that some of the damage, yes, it's done in the past, is cumulative, maybe lingering there and become cancer over time. But if you stop now and protect now, you help keeping those at bay and not add to the new cumulative damage.
Yeah, makes sense.
Are then there are some preventative work that you can do too. Some of the skin cancers develop in precancerous forms on the skin, especially squamous cell carcinoma. Many squamous cell carcinoma arise in actinic keratosis, which is treatable. So you can treat actinic keratosis to prevent getting squamous cell carcinoma in future. We will go over different types of skin cancer
Yeah,
and
yeah,
more later.
yeah. Yeah, that's really interesting. One of the things I've shared with you off camera and I've shared on social media with my community is my recent stage 1 melanoma diagnosis that I had here. It was a little mole and it had doubled in size in 1 year. I was only going to my dermatologist once a year. Now, of course, I'll be going every 3 months for the rest of my life. But it was really interesting because my doctor had said it probably is a result because it was on my left side, and when I'm driving it comes through the window, so not even windows are protecting us from those UV rays. And over the years it could have taken a long time for this to have developed, because at the end of the day when they took it out of me it was the size of a golf ball, but the mole was teeny tiny.
Right. This brings up a few things that I would like to
Oh,
discuss.
great.
As for glass, you are absolutely correct. Glass blocks UVB, but not UVA. And UVA causes skin cancer and also skin aging. So you're right. When you're mostly the driver in the car, your left side is more exposed. We need
Right.
to wear sunscreen, broad spectrum sunscreen to
Hmm.
block UVA when we are behind glass. You also mentioned that you had a mole for years and it became melanoma. About half of melanomas grow in pre-existing moles and some grow from normal skin. So in terms of prevention and what we can do now is early detection, self-advocating and doing skin cancer screening. Yet another thing that we as middle-aged women can do, or everybody should do that at any age.
Right.
And we
Right.
can go over that.
Yep, we're going to do that too. I always say to my community, we're now in a position where we need to rebuild our healthcare team. And so that includes a dermatologist, right? If you don't have one on board, now is the time to get one on board, right? You might have a fitness instructor, you might have a therapist, you might have an OBGYN, you might have a preventive cardiologist. You need a dermatologist too. So help us understand the different types of skin cancer, because I think it's really important to know all the things we're dealing with. Like, I have a partner who has different types of skin cancers. His are the basal cell, right? I know you mentioned the squamous cell, and I had melanoma, right? So go through all of these and tell us what we need to know about it.
Sure. There are many different types of skin cancer, but the most important ones we can discuss today.
Mhm.
Basal cell carcinoma is the most common type of skin cancer. About 2 million people in the United States develop that per year, and the number is on the rise. That also turns to be the most curable and least aggressive skin cancer, thankfully. I would like at one point go over like what to look for it,
Yeah, no, what is it? Describe what each one kind of looks like too.
Sure, sure. So basal cell carcinoma um, has different subtypes, and those subtypes can show up on the skin a little bit differently. Nodular basal cell carcinoma usually looks like a little pimple, a red bump. In people with the skin of color and a little bit darker, that can be a blue or gray bump. But in whiter skin, usually is a pink or red bump. Looks like a pimple. But patients come to me and say, I've had this pimple that doesn't go away, has been there for a while. So any pimple that lasts more than a month or 2 months needs to be checked.
Mm.
If you let go of it, then you notice that it grows, it starts to bleed, it can ulcerate at later stages. Superficial basal cell carcinoma is more like a red patch. It may not be raised much, but it could be shiny in different lighting. It could be a little scaly. It can itch at times. Morpheaform or infiltrating basal cell can look like a scar, a white spot. Once I had a 35-year-old young man who came with a little dent on his nose, and there was no history of trauma. All these are basal cell, but can present differently. So a bump that doesn't go away, the skin colored, usually pink or darker blue-gray, a red patch, a scar-looking patch that doesn't go away. Basal cell carcinoma can easily bleed, can itch. I've had ladies come and say, whenever I wash my face or exfoliate, this one spot bleeds, but I don't see much there. So bleeding should be another, concerning
Mhm.
sign. Basal cell carcinoma, as I mentioned, has a very good prognosis. However, it can happen in a very cosmetically and functionally important areas like tip of the nose, eyelid, lower, upper. So even though it has a good prognosis, we definitely would like to catch it early because cancer just grows. Any cancer, cells become cancerous when body cannot control their growth, right? Cancer by
Mhm.
definition grows. So a basal cell can grow. If it is in a cosmetically or functionally important area, it can keep going. It can go through the eyelid. It can go through the nose. I have seen those cases, but those are usually ones that have been ignored for a couple years or more at least. So basal cell initially just locally, like eats through the tissue and keeps going. And if it is ignored for many years, then it can even metastasize. But that's
Mm.
rare. Second most common type of skin cancer is the squamous cell carcinoma. The squamous cell carcinoma can be a little bit more aggressive. That also has different subtypes. Some behave, differently, grow more slowly, and some can be aggressive and jump on the nerve, especially on head and neck. So that, is another cancer that we have to be very careful about. It can show up as a dry patch that doesn't go away. no matter how much you moisturize. It can sometimes look like a volcano. There's a subtype that grows really fast, like a little bump that grows and has like a crater at the center. Um, this is the type of skin cancer that I mentioned can grow from precancerous actinic keratosis. Some of the older patients that I see, they just think that their skin is just dry on their face. They don't know better. And they come with many, many actinic keratosis accumulated all over their face, neck, V-neck, areas that has been sun exposed over years, so gradually that they just didn't think much of it. And they think that, oh, it's just dry skin. But those are actinic keratosis. They don't respond to moisturizers, 1 in 10 actinic keratosis can become squamous cell carcinoma. So if you have 20, 30, right, which easily
Right.
you can accumulate that many throughout your lifetime, the risk of developing squamous cell carcinoma goes up. So that's another preventative thing that can be done. Treat the precancerous, right? So it doesn't become a squamous cell carcinoma. Then let's talk about melanoma. Melanoma is more aggressive, can be deadly, can grow faster. Melanoma cells, unfortunately, have a higher ability to erode into blood vessels, lymphatics, and jump to the other parts of body, causing metastasis and become fatal. There are different types of melanoma too. Science has shown that many melanomas are UV induced, but then there are some that are not. Those are the type of melanomas that are found in the genital area, soles, between toes. And that's why we will talk about it later, how it's so important to do a good skin check, right?
Right. Right.
So melanoma is thankfully only 1% of all the skin cancers that we see, but it's the most serious one. And then there's another one that it's even 40 times less common than melanoma, and that's Merkel cell carcinoma. I think I should bring that up because it was
Yes.
recently. And Merkel cell carcinoma, unfortunately, is also very aggressive and can be deadly. Merkel cell carcinoma can look just like a pink bump. Now, melanoma can also look like a pink bump, but most melanomas have more color in them. Most melanomas are blue, gray, brown, black. However, there is a subtype of melanoma called amelanotic that is colorless and can be pink. So anything growing fast on the skin, something new, ugly duckling sign, like something that doesn't look like anything else that you have on your skin,
Mm-hmm.
no matter of the color, should be assessed by a specialist, by dermatologist.
Yeah. There's something called the ABCs of melanoma.
Yes,
Can you share that with us?
absolutely. So to help everybody detect melanoma early, because early detection means early stage cancer means better prognosis. They have come with this mnemonic to help us diagnose ourselves.
Right.
So when you look at your skin, you always should look at old moles and new moles. And if you see any changes in A, B, C, D, E, go see a specialist. Asymmetry. So if the color or borders don't match, one side is darker, one side is lighter, one side the border is very smooth, the other side is jagged. That's how I look at asymmetry. Something that when you draw a line in between, somehow it doesn't match color-wise,
Mm-hmm.
border-wise. Now, this mnemonic elaborate on that more. B specifically stands for border. Sometimes a mole can go cancerous and only one side of it starts to grow. So that causes a border asymmetry, right? One
Mm.
side becomes jagged. Most benign moles have a kind of a smooth border, not a jagged border. After BEC, color. Now, most people think that if a mole gets darker, that's a bad sign. That's correct. But also, if a mole gets lighter, that's a bad sign. So a
Mm,
brown mole that turns blue, gray, black is as worrisome to me as a brown mole that turns white or pink. So color can go either way. Then D is diameter. Another misconception is that if it is flat, it's okay. If I don't have a mirror to look at my back, I'm gonna check with my hand. That's not enough. Melanoma initially can be flat. There's one subtype nodular that to begin with is raised. Most melanomas initially are flat and keep increasing in diameter. So it's not,
mhm. That's what mine was.
so diameter is very important.
Mhm.
If a mole is expanding, getting wider,
Yeah.
that's a, that's a sign. And then after the diameter is E. E stands for evolution, any change, or elevation. One other thing that's good to remember is ugly duckling sign. Most of us make moles that are kind of similar. I have a darker skin, I have darker moles. I don't make a pink mole. Someone with a more like fair skin may never make a brown or black mole. Genetic, plays a big role in the color of our moles. So if you all of a sudden have a lesion that doesn't match the rest, that's your ugly duckling sign. That has to be
Mhm.
checked.
Yeah. Something just came to mind when you were talking about the ABCs and talking about the different types of cancer. And I thought to myself, people who have eczema and psoriasis on their skin always have these patches, right? And sometimes they're red and flaky, and sometimes they're whitish and flaky. Do you find that people that have these skin issues going on have a harder time recognizing or acknowledging if a new spot might be a troublesome spot, or it's just the regular thing that they're always getting?
Absolutely. That's a challenge even for a dermatologist
Yeah.
to find out. Many times, I tell my patients when you get a patch of eczema or psoriasis, treat it with your medications. If it is not budging, I probably need to know.
Yeah.
But yes, that's unfortunately a big challenge.
Yeah. Dr. Shurian, I can see why dermatology and skin cancer is so intriguing because there's so many things about it. Out here as a patient, we're just thinking we either have skin cancer or we don't, right? Whatever type it is. But you're bringing up so many things that I've really never considered looking at on my skin, if it's red, if it's purple, if it's bluish, right? It's we're living these such busy lives, and when we're in midlife and we're not only helping kids get out the door to be, in their adulting years, we're also helping our parents who are sicker and who might need more support. And so it's this is such a wonderful reminder of all the things to look for.
Yes, and put the oxygen mask on your face
Yes.
yourself first.
Right, right. Let's go back to risk factors. You mentioned sunlight exposure, and you mentioned aging, right? But what are some of the other risk factors that we should be aware of?
Sure, there are other risk factors. Um, if we divide them in two big categories, it will be environmental and genetic. Environmental is UV. Another thing is like some medications can be photosensitizers. Um, Hydrochlorothiazide is a very commonly used medication for high blood pressure. That is photosensitizing. Doxycycline is an antibiotic that can make you more sensitive to UV ray. So it's important if we are temporarily or not temporarily on any medication that makes us more sensitive to sun, even be more careful and avoid UV light. That's another environmental factor that comes to my mind. Immunosuppression is another factor. There are people who, for different reasons, have a lower immune system. Patients with HIV, patients who are going through cancer treatment, rheumatoid arthritis on medications that lowers the immune system. So that's another reason to be even more careful.
Hmm.
Transplant patients, because they are especially solid organ transplant patients, liver, kidney, they are on medications that lowers their immune system. So the organ is not rejected, and they have much higher risk of developing squamous cell carcinoma. Aging, we mentioned already. Family history. There are certain syndromes that run in families and cause more skin cancer. There is one that causes more basal cell carcinoma. There are dysplastic Neves syndrome, in which people have multiple different color, shape, size, molds. Those people are at increased risk of melanoma. History of sunburn. We mentioned this earlier.
Right.
You had more than 5 sunburns in life.
I've had like 250 sunburns. I mean, I can't even count how many sunburns I've had in my lifetime.
So that
Yeah.
unfortunately risk factor for you. And on top of that, you, the family history, whether other members have been more susceptible to skin cancer, can give you a clue about your genetics. Light colored eyes and blonde hair definitely are a risk factor. Although I want to mention, we see skin cancer in Latino, Middle Eastern. My own uncle has had basal cell carcinoma. So I hesitate to say certain skin type is prone.
Yeah.
Because it can happen in any race, color, but it's true that fair skin has a higher risk.
Yeah. What about tanning beds?
Tanning bed, huge risk factor. They emit UV, and the same way that UV from the sun is bad for us, UV from tanning bed is bad for us. A few years ago, this was going around saying that this type of tanning bed has a good UV. There's no such a thing, because we know both UVA and UVB cause skin cancer. UVB now is the one that causes tanning, UVA more skin aging, but both contribute to skin cancer. So tanning bed is a huge no and big risk.
So how are tanning beds even allowed to be here, right? Like, be part of retail spaces, drawing in young people that want to get a tan before they go to Florida or before they get married.
It's very unfortunate. Going to Florida, people say, oh, I want a baseline tan to protect.
Yes.
Baseline tan does not protect you. If you like the look, please get the spray tans. The technology has advanced.
Yep.
And they look beautiful. There is no tanning with UV radiation and tanning bed that is safe. And it's very unfortunate that it is still available. The same way that cigarettes is still available. There are many good people who are trying to pass laws to stop the tanning beds, to be available, but that's a battle that hasn't been won yet.
Yeah, that'll be a big one, but a tough one. I always think, are they in business with the pharmaceuticals, right? Are the tanning beds out there so that people have a higher risk of skin cancer, so that they have to seek more medical attention? There's more money, you know the whole healthcare story, right?
There is a combination probably of people who are after their benefits and they don't care, and unfortunately, lack of knowledge and ignorance probably is a combination of all.
Yeah. I have another risk factor here that you and I spoke about, number of moles.
Yes. It's been shown that if you have an increased number of moles, you are at an increased risk of getting melanoma, not other types of skin. So there are people that have more than 20, like sometimes 30, 40 moles all over their body. So then more moles you have, unfortunately, you are more at the risk of developing melanoma. And therefore, it's more important for you to be on top of detection. Monthly self screening and
Mhm.
also seeing a dermatologist.
What is the difference between a mole and a freckle? I mean, I am that person with a lot of moles. All my kids, I mean, we all get checked, right? But I have, you could connect the dots on my back, right? I have so many, and I've had a lot removed as well.
Great question. So the difference between the two is microscopic. So only under the microscope, based on um, the way the melanocytes, those are the cells that
Mhm.
have the melanin in them, are dispersed in different, like the layers of the skin, tells you whether it's a mole or is it a freckle. But I don't want you to know or worry about that because freckles can go bad too, right? Because they have melanocytes in them too. So anything that changes, whether it's a mole or freckle, it's a reason to see a dermatologist. But yes, there is a difference, and that's based on the look under the microscope. Usually,
Hmm.
moles, the melanocytes go deeper into the skin from epidermis, and freckles don't.
Yeah, that's so interesting to me when you just mentioned how deep a mole goes, because that was one of the things that my doctor shared with me. It's this amount deep in your skin. And then, so I had this tiny mole, right, which doubled in size, but it's still very small. But underneath was a golf ball sized tumor, which wasn't protruding from my skin. But it's so amazing to me how smooth everything could look. Yet all of this energy was going on underneath. So it's
Correct.
sort of like the iceberg, right? The mole is the tip of the iceberg, and then underneath is the tumor.
You said it right. And melanoma staging depends on the depth of the
Hmm.
melanocyte going down through your dermis.
Yep.
Yes.
Very interesting. Let's talk about prevention. And we've got two sections here. One is UV avoidance, and then the other is early detection. And we've touched on some of the things, but let's just really break them down for the listener here. Let's start with the UV avoidance.
So UV protection comes in different forms. One and foremost is to wear a good wide spectrum sunscreen. Wide spectrum means it has both UVB and UVA protection. SPF 30 or above, because when you get to SPF 30, you're blocking about 98%, 97 to 98% of UV ray. If you go higher, the added percentage is not that significant. But again, not 100%, right? With even with a SPF higher than 30, you never block 100%. So I'm going to come back to it. So first, a good sunscreen, reapplication, because sometimes we put it on and we forget even to reapply. It has to be reapplied. Wide brim hat, sunglasses, lip balm with sunscreen. That's another thing we forget.
Hmm.
Clothing that also protects us from UV. Many of them are available. So for beach wear, when we are under the sun, it's important to also invest in those. And then the second thing is really avoidance, because with all this protective gear, if I go and lay down in the sun at noon when the more UV is coming through, I'm gonna get some UV radiation. Now we need to live our lives. I'm not saying that we all need to go in a cave. We want to go enjoy outdoors. That's part of being healthy. It's just we have to be careful about it. Seek shade. Use the protective gear and seek shade.
Yep, yep. Okay, I have a couple questions to follow up on that. The first is I want to start with sunscreen, right? We have mineral and we have chemical. And there's so many there's a lot of information out there that the chemical ones are absolutely off the table, that you should not use them because of some of the UV filters that they use, and that they're harmful for the environment. And also that they can cause others that they can cause skin cancer because they're chemicals. So I want you to address that versus the mineral based ones. Now, I did have a dermatologist on another episode, and we were talking about skincare from a totally different angle here. But one of the things she had said was that the mineral one is great. However, it only lays on top of your derma. And so it doesn't soak in. So if you're someone who's going to be in the sun and you're going to be active and sweating and swimming, that's probably not the best choice because you want the protection to be soaked in, which is where the chemical ones come in. So I was just wondering, what is give us your thoughts on this and help us understand because we want to buy women, especially in midlife, we want our skin to look great and we're trying to get away from chemicals.
Correct. Correct. Um, I wish I had a chance to talk to your other speaker because I don't think I see eye to eye with your other speaker about this one issue. Physical or mineral sunscreens like zinc oxide, titanium dioxide, yes, the way they protect us is by bouncing the UV back, right? So you put that on top of your moisturizer, not
Mhm.
underneath.
Right.
The way they do, UV hits them and reflects back. But sunscreens also come in water resistant, very water resistant, and that is what shows whether they stay on you when you go in the water or you sweat and how long. Water resistance is supposed to stay on you 40 minutes if you're in the water and you're sweating. Very water resistant, 80 minutes. And American Academy of Dermatology recommends that if you are not in the water or sweating, reapply any sunscreen every 2 hours because they are not gonna last. So I go based on that. If a physical one is water resistant or very water resistant, and a chemical one also, is water resistant or very water resistant, I find them equivalent. I'm not gonna say
Okay.
absorbs, the other one doesn't absorb. But yes, the chemical ones act differently. So you put them on at least 15 minutes to go on out. You put them under your moisturizer because they kind of go into your skin, not very deep. And that's how they protect. They absorbs the UV and convert it, right? So it doesn't get to go into your skin,
Wait,
right?
so you're saying put on the sunscreen um
The
over your moisturizer.
one chemical one goes first on your skin to protect.
Right, right.
Moisturizer can go on top. But the physical and slash mineral
Mineral. Mhm.
that is bouncing the UV back goes on top, right?
Yeah. Yeah, that makes sense. Yep, that makes sense.
But to me, both of them are effective. It's just you have to compare apples with apples, oranges with oranges. Water resistant, very water resistant.
Yeah.
And you also brought up their safety. Should I talk about it or
Yes, please.
you know, sunscreens are considered over-the-counter products, but FDA still looks at their safety and efficacy. I believe in the science and I believe in FDA, and I truly trust that FDA, if they have enough scientific data to show that these chemicals that are used in chemical sunscreens are harmful for us, they will ban it. A lot of studies that have been done with some of these ingredients that are used in chemical sunscreen that have raised alarm have been on rats, on non-human subjects who have been fed these molecules. There are many studies that have looked to see how much of these chemicals that are put on our skin show up inside the skin, in our bloodstream, and none of this current scientific data is alarming us, and that's why FDA doesn't have enough data to ban these.
That's really interesting because there's a couple of dermatologists that I follow on Instagram, and they're very science backed, and they say that some of these ingredients are not even allowed in European products. And so that European made sunscreen is far superior than most of the ones that we see in the United States. I I don't know the science behind that, but I know that in terms of our food, right? The food system in the United States is far below what it is in Europe.
There are different standards
Yeah.
between US and European regulatory bodies. That's
Yeah.
for sure.
Yeah.
Um, but I tend to believe in FDA. And I know that if there was enough data, they would tell us. Now,
Right.
I kind of think that Europeans are a little bit more advanced in protecting the environment, and think more about the long-term effects of these products on the environment. And, if you can use European brands, those are as good. Those
Right.
sunscreens are perfect too. But I wouldn't stop using American brands or American sunscreen, the chemical ones, um, and choose to be in the sun for the worry of the chemicals,
Yeah.
knowing what we know now, Jill.
Yeah. No, that makes perfect sense. And another question I had was, if you said that the SPF really should be 30, not, it doesn't have to be 70, but at least 30, why are there products on the market that are made under 30? Is that just a marketing gimmick?
Probably there's no regulatory ban on selling those. But, and SPF 15 protects about 93 to 95% of the UV that can affect your skin. Um, but another problem is that when they check this in the lab, they use a thick layer and then they measure the SPF. In real life, we are not putting
Yeah.
as thick of a layer or as much, a shot glass about an ounce for the body, a full teaspoon for the face, right? So I worry that by telling my patients use SPF 15, and if they don't use it optimally, use
Yeah,
a
that makes
thinner layer,
sense.
then they
Hmm.
are protecting themselves less than 95%.
Right.
So that's why, like, okay, SPF 30, most of them are very elegant, still won't leave you with a residue or whiteness,
Hmm.
and they protect you. So, like, I guess it's just finding the middle ground.
Right, right. Finding what works for you, making sure it's applied properly. Let's go back to early detection. So I go once a year. Is for the general public, is once a year fine, except until something is found like on me?
So unfortunately, in 2023, there was a task force that was supposed to look into this and say how often people should get total skin exam by a dermatologist. And they couldn't find enough data to support annual exam recommendations. However, we all know that early detection saves lives. So American Academy of Dermatology strongly encourages everybody to do self-screen exam, and if they find something concerning, see your dermatologist. That's for general population. For people who have a history of skin cancer, in general, we recommend more than once per year exam by the dermatologist. Basal cell carcinoma, I normally ask my patients to see me twice a year. With squamous cell carcinoma, because it's a little bit more aggressive, every 3 or 4 months. Melanoma, every 3 months. And we do this for about 2 years after the cancer was diagnosed. If within these 2 years, we don't find any other primary cancer, and God forbid any recurrence, then we relax our standards a little bit
Mm.
and
Uh,
we extend the time in between the exams. But I believe it's very important that we all do monthly self exams.
Yeah, and also with the monthly self exams, it's hard for us to see in our hair, right? So, talk about what to expect when someone is having an appointment that's specifically just a mole check.
Yes, very important. I always look on the scalp. Melanoma happens on the scalp. All types of skin cancer can happen on the scalp. Men who are bald definitely have a higher risk, but I've seen many cancers on the scalp of women with thick black hair. So in a good exam, your provider will open up the hair in sections and look at your scalp. And then I tell my patients, if there is a hairdresser that you see frequently, ask them if they find something new on your scalp to
Mhm.
let you know, because it's hard to see your own scalp.
Yep.
Then in a good exam, you should be looked at everywhere where sun shines and where sun does not shine, because skin cancer can happen in the absence of UV radiation. UV radiation is one factor, right? A big, huge factor that increases the risk. But without that, there are other risk factors and, you know, spontaneous mutations that can cause skin cancer. So in the genital area, melanoma happens in the genital area, men and women, between toes, soles, palms, under the nails. Melanoma can happen under the nails, and unfortunately, most of the time, it does not follow any of that ABCD.
Mm.
Melanoma under the nail can be just a straight vertical band that starts close to the skin and goes straight up. I always tell my women patients, whenever nail polish is removed from fingernails and toenails, please look. Take a moment to look. If you ever have a band in your nails, I need to know. The band can be gray, blue, black, pink. Now, again, in darker skin, it is okay. And sometimes you get multiple nails that can have a band. But lighter skin, less common, more cause for concern.
Mm.
So if there's a band, it needs to be evaluated. Melanoma can also happen in mucosal area. So when you see your ophthalmologist, they look at the back of your eye
Mhm.
retina. Dentists always check inside the mouth.
Mhm.
Your gynecologist looks at the vaginal wall. Um, so when my patients have had a melanoma or family history of melanoma, I also make sure to remind them of this and say to them, when you see your ophthalmologist, dentist, gynecologist, they need to know about your history, your family history, and check for melanoma in those areas too.
That
But
is such great information.
thank you.
Yeah. We're coming to an end of the podcast, and I want to cover treatments, and um I'm thinking to cover melanoma because that might be all we have time for since we're
So
already
I
an hour
stop
in.
and please feel free to stop me. So melanoma treatment depends on the stage of melanoma. Melanoma is staged based on its microscopic depth from the epidermis, the top layer of your skin, and going down, right? So stage 0 melanoma is just confined to the epidermis. That is treated with a wide local excision of about 5 millimeters on each side, made into an ellipse, cut out. Normally, that's it, right? When the
And is that done at the dermatology office?
Yes, it's done by
Okay.
a dermatologist. A dermatologist is completely capable. A surgical dermatologist is trained and capable of doing that.
So is this where the Mohs
No, no.
no. Okay.
This is
Okay.
wide local excision that you
Got
measure
it.
the sites, cut, send it out to the lab. The tissue is prepared overnight, different preparation than most, that saves melanocytes better, so it's more accurate. And it's checked to make sure all the margins are negative. God forbid if it's positive, it has to be redone. If the melanoma goes deeper than epidermis, then it's measured in millimeter, 0.1, 0.2, 0.3. And there are criteria based on like the depth, then you may have to go wider, 1 centimeter on each side, make it into an ellipse. Ellipse is always like 3 to 4 times the width. So that's why melanoma excision is bigger. And at a certain point, right, 0.5 millimeter or higher, the patient may need sentinel lymph node biopsy. That's when an oncologist surgical oncologist will do the excision, and at this time of the excision, they check the nodes that are close to where melanoma is. And if melanoma has gone to the node, then this patient will need imaging, CT, PET, right, for further workup and staging, and may need some systemic treatment. It can be in terms of immunotherapy or chemotherapy. So when it is still just excision with no lymph node search, dermatologist. Otherwise, it goes to surgical oncologist, and God forbid if it is more spread, then also an oncologist gets involved. For non-melanoma skin cancer, basal cell carcinoma, squamous cell carcinoma, there are different modalities for treatment, but because we are short on time, most micrographic surgery is the gold standard. That is the one that the surgeon removes the cancer with the least amount of normal skin around it. It's tissue sparing that way. You wait in the office, the most surgeon who is board certified, fellowship trained, right, looks, the technician prepares the tissue. That most surgeon is trained to look at the pathology under the microscope, make sure everything is taken out. If not, repeat it layer by layer to get the cancer out. That way, the skin cancer is taken out with minimal amount of normal skin around it, because that's sufficient for non-melanoma skin cancer. And then most surgeon is also trained in repair. In certain cases, repair is also delegated to a specialist, oculoplastics, ENT, or plastics, but that most surgeon will decide about that. One thing I should mention is that there are rare cases of squamous cell carcinoma that can go deep, and they need further workup like lymph node dissection or radiation. But those are really rare. And most surgeon is trained to be able to catch those and guide the patient.
So what's the biggest, so when it's melanoma, such as what I had, that's when a stage 0 can be taken care of in the dermatology office. But when you get to stage 1, then that requires something completely different.
Many stage 1s, those are melanoma that the depth is still below 0.1 millimeter. Many of them can be taken care of by a dermatologist. But it used to be that we didn't require lymph node dissection if the depth was below 0.1. But now there are other factors that we look at. The pathology report names them: ulceration, mitosis, regression. So multiple factors that are all microscopic are reported on the pathology report. And based on those and the depth, we decide whether this patient is a lymph node dissection. If it is a lymph node dissection, that goes to surgical oncologist. So not all stage 1s need to go that way. Most of them are also taken care of by dermatologists.
Okay. Yeah. So I had surgical oncology and a plastics. And I think what my dermatologist said was also because of the location, of being on my neck and, being near all these nerves, which by the way, they snipped one of the nerves that go from here to my ear. So, but you know what? I'm fine. And, thank goodness I have a very old friend of mine who I lived with when we were just out of college. And she got married very young and had 2 children, and found out she had stage 4 melanoma. And she passed away at a very, very, like within a year. And when I had my diagnosis, all I could think about was her, and how grateful I am that I've been able to have a dermatologist on board on my healthcare team, to help me navigate this, because that was a really horrible time to witness that.
Oh, I can only
It's
imagine.
really serious.
Yes,
Yeah.
melanoma, quite serious. Please
Yeah.
do your skin exams,
Yeah.
everybody, and please see a specialist. I believe
Yep.
that anything that we need to go to the specialist, and the dermatologist is your advocate, is the person that will help you navigate skin cancer. And I hope everybody will be in good hands.
Yeah. And I just want to say for the listeners that while we don't have time to dive into all of these other modalities that can be used, there's targeted therapy, radiation, immunotherapy, there's topical creams that you
Correct.
can use, right? So for the listeners out there, what is a trusted resource besides, of course, this podcast with you? What is a trusted resource online that people can go to and get the answers that they might be looking for?
Sure, sure. Well, I recommend the Skin Cancer Foundation. That's
Mm-hmm.
a very good resource. Also, American Academy of Dermatology has a section called Public that provides information. If God forbid you are diagnosed with skin cancer and you need a Mohs surgeon, you can go to American College of Mohs, ACMS website. I wrote all these websites down just in case you ask me, but that's the gist of it. Like if you
Okay,
Google Skin
great.
Cancer Foundation, American Academy of Dermatology, or American College of Mohs surgery, you should be able to find information.
I will add that all to our show notes. Dr. Shurian, it was such a thrill to have you on to talk about this topic, because there is so much conflicting and confusing information out there in the metaverse. I know you aren't on Instagram and social media, but a lot of people are. A lot of doctors are. A lot of women navigating menopause are. And it's really overwhelming for us to find trusted resources and know one day you hear something's okay, the next day it's not okay. And, it's just, it's hard to navigate. So we appreciate your time that
And I
you've.
appreciate you and all the help that you bring to all of us. Thank you.
Oh, thank you so much. It was such a joy to meet you, and hopefully I get to meet you in person one day.
I hope,
Not surrounding skin cancer, of course, because we're both in Chicago. But thank
yes,
you so much. And everyone, thank you for tuning in. And I will put all of the information in the show notes as well for you.
thank you.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.